All right, thank you, everyone. We'll give everybody a few seconds to start joining us here. Thank you again for joining us for our last plenary session today. We do have Dr. Brian Ahmedani, who is the director of the Center for Health Policy and Health Services Research and Director of Research Behavioral Health Services. He received his PhD and MSW degrees from Michigan State University and is fully licensed clinical and macro master's level social worker in the state of Michigan. Dr. Ahmedani also completed an NIH/NIDA funded fellowship program in drug dependence epidemiology. He joined the Center for Health Policy and Health Services Research at Henry Ford Health Systems in 2010 and was appointed director of the center in September of 2018. Dr. Ahmedani will be speaking on implementing zero suicide in health systems today. Thank you again, Dr. Ahmedani, for joining us today.
Well, thank you very much for the introduction, Kara. I really appreciate it. So thanks to everybody for joining today. I'm going to share my screen here, and then we'll get started. So thanks to everybody across the state of New York for joining today. It's really a pleasure to be here. I'm going to talk, I think you've already heard during this symposium a little bit about what happened at Henry Ford and how we originally launched zero suicide at our system. I'll quickly review that, but I think Dr. Coffey already presented on that. So what I want to do today is tell you a little bit about what we've been doing since. I want to tell you about three different types of initiatives that have happened since that time, and why those are really important to really support your adoption of this program across so many different areas in New York City. So we have three separate initiatives. I'll go through all of them, but I want to talk a little bit about some of the background. Let me get started here. Okay. So I want to first of all thank the National Institute of Mental Health, SAMHSA, and also actually Blue Cross Blue Shield for funding to support all three of these different initiatives. The NIMH grant actually includes several health systems across the country. Most of them are Kaiser sites. That's part of a national evaluation of zero suicide. So I'll talk a little bit about that. I also want to share a little bit about our movement through SAMHSA to do an emergency department zero suicide program to really bolster our program here specifically at Henry Ford across all of our EDs, and then also tell you about a statewide program that just kicked off, actually, that we're leading here across the state of Michigan, focused on implementing suicide prevention practices consistent with zero suicide across all the provider organizations in the state of Michigan. And we're, I'm very thankful for that opportunity. It's brand new and really exciting for our team here to be able to launch all that work across the state. And so, all of these things are telling me that it's certainly possible for you to do all this work across New York. So I'm looking forward to talking with you about that. But before we get there, let's just all start at the same place. And so let's go through a background. You've probably seen this at every single presentation you've seen during this symposium, but it bears repeating because the nature of this problem and the scope of this problem is so big that we really sometimes don't spend enough time really talking about all that we need to do and all the opportunity that we have to make a difference. So suicide, obviously the 10th leading cause of death in the US as of 2019, that's probably changed with COVID. The final numbers for 2020 haven't come out yet. The preliminary numbers obviously have shown that, we had a rising national suicide rate every single year, year over year, for 20 years straight in the United States. And that includes pretty much every state in the country, where we've seen a rising national suicide rate. The rates have increased by, are about 25 to 30% higher than they were in 2000 now. And that includes upwards of 48 to 50,000 people who died by suicide, just as far as the most recent year where we have final data. We're pushing well over 1.5 million people a year across the country who are attempting suicide. And actually, more specifically, well over 10 million people across the country a year who are thinking about suicide. That's a pretty significant portion of the United States population if you consider there are 325 million, 330 million people across the country, and 10 million of those are having suicidal thoughts every single year. It's a pretty big scope. It's much bigger than the scope that we think about when we narrow it to the people who are dying by suicide. Obviously, we want to prevent that. But if we think more broadly about the people who are in our capture and the people that we really have to touch to prevent those 48,000 people from dying, the scope gets bigger, but the opportunities are also greater. And so we have an opportunity to make a difference. Really, what's important here is that the suicide rate is the only cause of death right now in the US that over the last 20 years, in the top 10, 20 leading causes of death, that has actually been increasing. All of the other leading causes of death in the US have annual rates that are either relatively stable or have actually been dropping pretty substantially over this period. So while those numbers are still pretty high, suicide is actually the only one that's actually been increasing across this entire period. And so it bears our focus. And yet, if you go back to the National Strategy on Suicide Prevention in the early 2000s, you'll see there is absolutely no focus on healthcare systems and what we could do in healthcare systems to do a better job of prevention. It wasn't in 2012 that became of importance, and it's because a lot of the work that we've been doing to try and not only recognize how healthcare systems have opportunities to prevent suicide, but also that there are actually interventions and approaches that we can use in practice to mitigate risk. So here's some data. We published this, and I just want to give credit to Mental Health Research Network and all of our colleagues across the network who participated in this. This is data from almost 6,000 people who died by suicide over several years, and all of the healthcare contacts that they made in the year prior to their death. And what we found, and I show this pretty much every time I talk, to reiterate the fact that we have an opportunity to prevent suicide in healthcare systems. But what we found, and I'll just keep repeating this probably every day till the day I stop giving presentations, but what we found is that almost everybody makes a healthcare visit before they die by suicide. Over 83% of people who die by suicide have a healthcare visit and appear within a year before they die. Almost 50% within a month before they die. And most of those visits are happening in primary care settings, emergency department settings, hospitals, but mostly primary care. And almost over half of people who die by suicide do not have a mental health diagnosis. Only about a third of the people who die by suicide ever touch behavioral health in the weeks before they die by suicide, actually in the whole year before they die by suicide. So that means most of the people, so even though the people who get to behavioral health are usually at the highest absolute risk, that means they have the highest chance of dying by suicide or attempting soon after those visits. Actually, the greatest number of people are actually not touching that system. They're much broader into other settings like primary care, where most people get their services. And so that really gives us some information about how we need to think about zero suicide and how we need to focus the implementation of our practices. We really need to think about how we can put high intensity services in the settings where the fewest people go, but who are at the highest risk. And then make sure that we also have low intensity services in those settings where there's lots of people going to get care and most people are not at risk. The base rate is very low, but where most people are touching before they die by suicide. So we have to have something across all of those settings with a focus and intensity that matches the base rate so that we can best use our resources and our staffing and really create care pathways that are focused on identifying and treating suicide and using our resources and staffing the best possible. In 2012, I just mentioned this, but the US Surgeon General and the National Action Alliance came out with the most up-to-date national strategy for suicide prevention. And for the first time ever, this report acknowledged that healthcare systems have a core responsibility for suicide prevention, that we actually can do something about it. You know, just 10 years earlier, like I mentioned, there was a thought that there really wasn't anything we could do about it in healthcare systems. And that it wasn't part of our mandate, that suicide prevention was not part of the core practice. And it's not that there wasn't a recognition that people were touching the healthcare system, but there was a recognition that there really weren't any interventions or practices, screening tools that we could actually use that could work in practice. And also a recognition or a belief at that time that, you know, if people wanted to do something and they were going to do it. And there wasn't really much we could do in our healthcare systems. So at that time, what we were doing is just having people sign contracts to promise us that they weren't going to attempt suicide until we saw them the next time. And yet over this last duration of time, we've recognized that actually really does not work at all. And we've come up with different approaches to help facilitate better care. So we now have not only a mandate and a responsibility to provide care for people in healthcare systems and to pursue prevention of suicides, but we also have the interventions, the tools that we can use to implement in practice. And so right now is the golden era of when we need to make that switch, to actually make that switch to do the work to prevent suicide in our care. And that's what we're all here about today. That's what this conference is about, is the recognition that we have the opportunity to pursue perfection, that we have the opportunity to say that we will always work towards and strive to prevent every single suicide that we can. So more recently, and I should also say that, you know, in the state of Michigan, I'm chairing Governor Whitmer and the state's Suicide Prevention Commission. And with that role, we're also coming up with some of the same approach, some of the same mandates, not mandates, but some of the same resources and opportunities and reports specifically to the state of Michigan. I know that there are a lot of initiatives underway in the state of New York. And so, you know, piggybacking off of those initiatives on top of national initiatives, we really have a premier time in our period to actually make some change. So, and I'll also then say, well, you know, the Joint Commission has done a lot of work as well. Just a few years ago, preceding this patient safety goal, they released a Sentinel event alert, which called on and recommended that all healthcare systems screen for and treat suicide risk in all settings. Now, the mandate that was pushed forth in the patient safety goal specifically focuses that and it requires that we do suicide prevention screening and treatment for people with behavioral health conditions. But the recommendation is actually much broader from the Joint Commission, saying that we actually think you should be doing it everywhere, but we're going to specifically mandate that you do it for people with behavioral health conditions and in hospitals, because that's their jurisdiction. So let me start with zero suicide. I know you probably are familiar with the SPRC website, zerosuicide.com, but Henry Ford actually, is probably Dr. Coffey illuminated in his presentation. Henry Ford is really who started zero suicide. The program started right here in our organization, and due to a lot of people who wanted to pursue better care for our patients. And it took a group of people who were pushing forward to pursue a goal of zero defects in care that we believed at that time, our organization believed would lead to zero suicides. So it was before any of these interventions were created, but a belief that there is something we could do about this, that we restructured our care process. We made sure all of our providers were trained. We really focused on access and lethal means, which was one of the few interventions that had some evidence back then. And we really focused on providing better care overall for our patients. And after doing that, we saw a pretty substantial 75 to 80% reduction in suicide deaths over time in our health system. And so that initiative, coupled with the fact that there has been so much research that's been done throughout the 2000s, the development of DBT, CBTSP, CAMS, screening tools like the PHQ-9 and the Columbia, safety plans, all of these things have literally been developed within the last 20 years. If you think about any other medical condition, most of the interventions we use today are hundreds of years old. This field is in its infancy stages, but yet we have all of the tools now. So we are, like I keep saying, in the opportunity phase of being able to implement those things into practice and to use not only the knowledge that's available and the structure that we developed at Henry Ford, but also piggyback on all the research that's been done across this entire time. The National Action Alliance convened and also reiterated the fact that there needs to be a focus on zero suicide. SAMHSA has pushed forth zero suicide, and we also have now zero suicide adopted by well over 20 countries around the world in their national health systems and their local health systems. This thing is growing like wildfire, and it's because it's infectious. It's because it's because people can get behind it. It's audacious, it's bold, but it's exactly that we need to make a difference in suicide prevention. Speaking with my scientist hat on, my administrator hat on, my clinician hat on, all of those things are what we need to really, we need the evidence, but we also need the leadership and the bold vision to push these things forward. So we've created several documents nationally. At Henry Ford, we have published, freely available for anyone who wants them. Feel free to go. All of our Henry Ford zero suicide guidelines for behavioral health services, they are freely available. All you have to do is go to our website, push that in, and just enter your name and contact information, just so we have some log of where our tools are going. And you'll be taken to a page to freely download a PDF copy of every single one of our guidelines from developed by our Behavioral Health Suicide Prevention Task Force. And these guidelines have been updated over time. We developed our original program, but one of the hallmark characteristics of our program has been ongoing rapid cycle quality improvement with integration of evidence-based practices. So as we learn more, we begin to continue to implement more over time. You can also go to zerosuicide.com, as I think most of you are aware, to get all of the national tools that are available from lots of different places, including links to our materials at Henry Ford. And here's just kind of evidence to show that the suicide rate among our behavioral health population declined 75 to 80%. We were able to sustain that for almost 20 years now. I will say that, obviously there have been a couple bumps in the road, but we have largely sustained that for well over 20 years. And you can think about all the numbers of lives that have been saved because of that, just because of the kind of care that has been implemented. So I really want to, first of all, thank all of our clinical staff and leaders over time for all the work that they've been done, starting with Dr. Coffey, now, with Dr. Kathy Frank, who's just an incredible leader of our program and clinical architect of the work that we're doing. And so, that takes me to the next phase, which is the first part of what I wanted to talk about today. And that is our Zero Suicide Evaluation Project, which includes Henry Ford Health System and several regions in Kaiser Permanente in partnership with lots of other organizations across the state. This is a U01 award, which is a NIMH grant, which is a research grant focused on, and what we're doing is a specific set of tasks. So we're in the final couple years here of the grant, but I just wanted to give you an overview of what kind of progress we've made so far. If you've seen some of the things that I've talked about, you may have seen some of this already about what we're doing, but for those of you who haven't, our main goal in our Zero Suicide Evaluation Project across 6 different health systems and 9 to 10 million patients a year. We're doing things a couple things that are really important. First, each one of these health systems and regions has chosen their local implementation plan for how they want to implement zero suicide locally. And that's really important. We're not doing a clinical trial in a little lab that has everybody randomized and only certain numbers of people eligible. This is real world practice with every patient in every single one of these health systems. And it's these health systems' decisions about how they're choosing to evaluate zero suicide, or how they're choosing to implement zero suicide in their care systems. So what we've done for the grant is to specifically partner with our health system leaders to understand and map what they're doing in their systems, to get a better sense of the timelines for their implementation, the specific interventions they've chosen out of the menu of options that are available on zero suicide, and to work with them to develop the quality metrics that they think are important to help drive their programs. Because those are the metrics that most places will want to implement. They're health system driven metrics, not research specific metrics. We're also developing research specific metrics, but more importantly, we're developing a set of metrics that the health systems have determined are important to them and will help them with their local quality improvement. We're also evaluating the fidelity to those metrics. You'll see in a moment some of the initial data just of the baseline phase, and de-identified, so you're not identifying which site is which, but evaluating the fidelity. So are we doing the things that we said? It's one thing for a health system to say, hey, we're going to start doing safety planning and screening and assessment and increasing access to care. It's one thing for systems to say they're going to do things. But then are they actually doing it, and are they doing it with fidelity is the next question. So that's what we're measuring. We're trying to see, are we actually doing the things that we said we were going to do? And are we doing it when we're supposed to be doing it? So we're measuring those things as part of our evaluation. The next thing we're doing is also measuring suicide outcomes. And we've been obviously collecting some preliminary data from baseline time slots. But what's really important here is that we're trying to see whether or not implementation of these practices and whether or not there's fidelity to that implementation leads to changes in suicide outcomes for those patients. And what we're doing is looking at this at the population level. So sometimes research projects say, well, this individual benefited, but what health systems want to know is whether or not they made an impact or a dent in their care population. All of your quality departments, I'm sure, have a passion for understanding whether or not whether or not they're making a dent or an impact in reducing the outcomes in their overall population. So that's what we're doing. That's what this project is specifically focused on. It's not an individual level project. It's a health system population level project where we're evaluating the processes, evaluating fidelity to the processes, and then looking at whether that had any impact in overall outcomes for suicide attempts and deaths. To do that, we're doing an interrupted time series and a stepped wedge design. So basically, systems are, we've combined those processes. So systems implement those interventions at their schedule, and then we use different methods specifically to measure not only each individual intervention, but the bundles of interventions that were packaged together and put into place all at the same time. And each site then is its own control before and after implementation, but they can also be compared across sites to see when other systems aren't always on the same schedule. So if we see changes in one system and not another that's acting as a control site, we're able to make more interpretation of changes and how that's being impacted by different types of implementation across places. The 6 systems are located in 6 different states across the country: Michigan, Washington State, Colorado, Oregon, and California. I guess that's 5 states. We have 2 sites in California. All of the patients have some type of insurance coverage, either Medicare, Medicaid, so public or commercial insurance, or are covered in some way. The reason we do this is to have complete capture of all of the outcome events. You can implement all of these processes in any system and measure your local measures, but in order to get complete capture of the outcomes in suicide attempts, we needed to have a total capture population, so that we can get those data when people show up at other ED systems outside of our care population. And we use all the infrastructure developed by the Mental Health Research Network, which includes data structures and harmonizing the way that we use our data across systems. So we take all of our EHR, electronic health records, and claims data and put them in the same data format and variables and definitions at each site, so that we can use the same specifications and measure the same thing at each place. Like I said, this is 10 million patients a year across all of these places. And really, it's focused on all of these different care settings: outpatient medical specialty settings, primary care, inpatient emergency department, and mental health specialty or behavioral health specialty settings. So not every system is choosing to implement in all of those care systems, but we're able to measure changes for each of those different care systems. And so most of the work that we're doing really focuses on these clinical components, which are, implementation of the identify, so which screening tools and assessment tools are each system choosing, which engagement approaches are they doing, care coordination, safety plans, contact, different types of contacts and access approaches or engagement approaches. Are we treating, what kinds of treatment are we implementing? Is that focused specifically for suicide prevention, or is it for, and then how are we handling transitions? Are any of these systems doing some of these things? And all of the systems are doing a range of these types of things. So that makes it both an opportunity and a challenge to measure the different types of implementation across all of these places. And we do have official state mortality records, EHR and claims data, and we're developing all these metrics so they can be used and generalized in practice. And they're not special research metrics that most people can't get a hold of. These are going to be, generalizable metrics that everybody can use. When we first started charting out the work that was being done across all of these places, it started to get quite chaotic. So this is how we defined all of these kinds of different programs and interventions that people were affiliating with zero suicide. And so you see that it can be pretty complex, and we were trying to make sense of there's all these different kinds of screening and assessment going on, suicide prediction modeling, and identify there's all these different engagement approaches, treatment models, and transition approaches, all of which are being implemented in different ways across places. Very much the way that many of you are choosing to implement them in your places. There is no standard implementation practice. So we tried to get a sense of this. So what's the general flow? And we said, okay, there starts with some kind of screening and assessment, which then triages into some type of more detailed assessment, safety planning, and then coordination of a care pathway that includes several levels of care, as well as the integration of follow-up after care. So we tried to streamline it a little bit and to put different kinds of, tried to make sense of a pathway of the different kinds of interventions within those buckets that zero suicide has pushed forward. The initial set of metrics, and the Kaiser Permanente, we developed these metrics in partnership with the leaders at Kaiser and Henry Ford. And Henry Ford's been able to share a lot of things over time, but this is new in Kaiser, and I just want to, they specifically allowed sharing of these initial metrics, and the implementation processes that they push forward were put on a nice big story on zerosuicide.com that kind of details all of the implementation practices. So I just want to say thank you to them for their willingness to be bold and to share some of these initial things that we've worked on together over time as some of the initial quality measures that we're focused on. So we're obviously developing a lot more. We're focused on screening measures, assessment measures when screenings are positive, safety plan measures. We're focused on some of the outcome measures and some of the follow-up measures that are required. And many of these are piggybacked onto the HEDIS metrics. You'll see some of them here. So I'm not identifying any specific sites or any specific regions, but more so just giving you a bigger picture of some of the baseline data that we started measuring. You can see some of these systems had done a really good job of implementing assessment, and some of them were in the process of beginning to implement some of these assessment tools. You can see that we had a pretty stable rate of follow-up after ED or discharge within 7 or 30 days following a suicide attempt, ED visit or inpatient stay. And so these are just baseline numbers prior to implementation of some of these practices. You can see some of the self-harm baseline characteristics before implementation, and you can see that. So this includes Henry Ford plus all of these other sites, and you can see, how there's some variation, but certainly some bucketing or general numbers that are usually there. And so I show that to kind of encourage you, because we've developed some of these metrics that many of you can adopt locally, and these are health system derived metrics that they told us were important to them. And that's why I kind of show you that we've been able to do that quarterly, and it's been pretty straightforward for us across all of these participating systems. What have we learned? Well, some of these things are easier to do than others in the evaluation. We've learned a lot about, we don't know what type of suicide risk assessment is being done. There's all sorts of tools that are being used. Most sites are using the Columbia, but there are other other assessments that are being done. And how do you weigh those different kinds of approaches? So we're working on figuring out some of these things. What should count as a follow-up contact is another question. So that we've been trying to work through. So let's say we contact somebody following an ED visit for a suicide attempt, and we're doing a caring contact. there's a lot of ways to do carrying contacts, but how do we count that when we're doing, is it okay if we just send an email or a phone, or do we actually physically have to talk to somebody? Do they have to come in for a visit? Can we do it the same day that they're released from the ED, or does that not count? Is that cheating? It's like saying goodbye to somebody as they walk out of the hospital, or is that have to be a separate activity? So we certainly feel like it needs to be separate, but then thinking through all the different mechanisms of contact these days, patient portal messages, all sorts of things that, and what's the weight of those different kinds of things? So each of you, and I tell you these challenges because we had to make decisions locally. You're going to have to make these decisions for what you think should count in your site, based on your local protocols for what you're trying to do. And we published this in a paper, and want to thank Bobby Joe Yarborough, who was the first author on that. Also published that chaotic mess of all those implementation processes. Thanks to Julie Richards, who led that work. But we're really trying to figure out some of these challenges. So I encourage you to think through some of these things before you do your local implementation. The other things are, gosh, it's pretty easy for us to use a set of standardized codes to measure suicide attempts. We've been doing that for over a decade in Mental Health Research Network, using a series of different algorithms and validated codes that we've been working with, that we published dozens of papers on. That's easy for us. It may not be easy for you, but we've got all the tools for you to help you to figure out how to do that. But how do you document a safety plan? And is it documented? Is it written out like just in a chart note that says, hey, we did a safety plan? That's a lot harder to measure than if it's in a separate document that can actually, that's actually part of the EHR. So there's different ways that people are documenting safety plans, and then the ways in which we measure them are either more difficult or easier, depending on how people are doing that. And then, the thing that's really challenging, we certainly can figure out that somebody made a behavioral health visit, but then the real question is are they actually getting that visit, a suicide prevention specific visit? Like, did they get CBT, SP, or DBT? And what was the quality of that care? Every therapist who graduates school will tell you that they do CBT, but many of them don't know what even CBT actually is. So I encourage you to work with your clinicians to make sure they're trained appropriately. It's one of the hallmarks of our program at Henry Ford. What else are we doing? We're working on, I mentioned some of that other work that we're doing, but I wanted to say that we're also trying to see whether the opioid prescribing guidelines as a means reduction approach had any impact, because those things were happening at the same time we've been measuring all the zero suicide implementation. So we're doing that. We're also generating a lot of coding and specifications for measurement of safety plan documents, not only to see whether or not they were done, but also to see whether or not they were populated and whether or not those populated safety plans were changing over time. So I also want to take a second to mention our SAMHSA grant. This is a really important project and endeavor for us at Henry Ford, and it's a 5-year program to really revolutionize the way that we provide our ED zero suicide program. So we've, as part of this initiative, we had already been doing some screening, but we used a more comprehensive and structured approach. So we now are doing universal screening for every single person who comes into the ED using the PSS3, which is the same scale that they used in the ED SAFE study. We then do an assessment, suicide risk assessment, safety plan, means counseling. You see all these things that are happening in the emergency department, treatment planning, really concerted effort to involve family members, much in the mold of our behavioral health program. and our integrated behavioral health integration primary care program that we've been doing for many, many years. But this is a more robust ED. We've been doing this ED program for a while, but this is a much more comprehensive program. We actually have health psychologists and care providers embedded now in each one of our EDs, and also the capability to do telemedicine consults across all of our EDs to be able to do some of this work even in the remote settings with our new EDs that are further out. We then make sure that there is a post-discharge caring contact with a care coordinator after discharge, and that includes a series of re-upping on the reassessment, checking in on the care plan, making sure visits are all set, that the visits are times that work for our patients, that we check in with them to see how they're doing. So that's obviously a caring contact. Reviewing safety plans means following up with family members, providing specific resources. And then another big hallmark is we connect them to a virtual telemedicine-based bridge psychotherapy program, which really helps mitigate the challenge of getting people into behavioral health services right away. It may be that their next BHS appointment, whether internal at Henry Ford or outside, isn't for a few more weeks. But this way we can provide them psychotherapy right away via our telemedicine portals. And this is a pretty innovative program that we've been developing here at Henry Ford, and has been an absolutely outstanding model, increasing access for patients who haven't traditionally been able to get access and who are often lost between different care settings in the process. It's really re-upping on our transition area. So then the next thing I really wanted to share with you is that all of these processes now, these zero suicide processes, are going to be over the next few years actually implemented in all of the provider organizations across the entire state of Michigan. We're working in partnership with Blue Cross Blue Shield on a new initiative called My Mind, which is an acronym that's really long, and that's my fault. So I had to add in all those words, and I liked My Mind. But we created this program that actually piggybacks on an infrastructure that Blue Cross has already available. So what Blue Cross does is that when they reimburse providers for their care, there's always a percentage that's left at risk. And so now systems over the next few years will be incentivized with extra dollars that are part of that at-risk bucket to actually do some of these suicide prevention practices across their state. So I want to across their local area. And so we're initially enrolling 5 provider organizations, the 5 biggest ones in the state. All of them will be working together to implement a core suicide prevention set of practices across their local health systems in partnership with us, and Henry Ford will operate as the coordinating center to help make sure all of that happens, including data capture and helping support with quality improvement. We are providing training for people at these systems because obviously this is something we've been doing for a very long time, and they asked for that. And we're going to be providing quality improvement support. Most importantly, most of this is really focused on quality improvement support and data infrastructure to help people facilitate this process. And then as part of a statewide CDC grant, we're actually facilitating a suicide learning collaborative with healthcare systems that includes a monthly or a quarterly call to talk through their local implementation challenges, barriers, opportunities, and work together as systems across the state, piggybacking on this new infrastructure in My Mind, to get people together and to do this work, and then to also support them to actually do the work and brainstorm together as healthcare systems across the state. So we're really excited about this new initiative, about this opportunity to push forward suicide prevention practices consistent with all of these models and all of the evidence-based practices that many of the people probably on this call who have developed. And so what I share this specifically as a model for going from one system, doing core implementation in behavioral health, how that spread to then including primary care, the emergency department, the hospitals, and all of our systems internally, to then spreading to new and revolutionized opportunities across multiple systems across the state, ironing out those processes, figuring out how to do the metrics, figuring out how to measure and get it and chart down all of these activities and make sense of all of them and make metrics out of all of them, to now a entire statewide implementation across all of these different kinds of health systems. So what I'm saying is that we have done this in Michigan. We have done this in different places across the state, and that each of you have the opportunity to use this as a model to work across your entire state in New York to really implement all of these practices. Let's let Michigan, let's let New York be leaders in the nation in suicide prevention and show the rest of the country how we can do that. So I want to thank all of the work that's been done to lead up to this moment, to all of these opportunities for our systems to work together, to work to make change, and to be, real vehicles of implementation across our places. So I just, I'm going to stop there with my presentation, but I'm happy to answer questions from anybody out there. So please do. I don't know if it goes in the QA or.
Yes.
Yeah.
We do have a few already.
Okay.
So first question is, how are the care coordinators funded, and are peers involved in the discharge process as well?
So our peers involved in the discharge process. So, we've been trying to figure out how to make this work actually. So some of the systems in our Zero Suicide initiative have used peers. Henry Ford used peers about 12, 13 years ago, and we did not have a good structure in place for it. And so shame on us. We didn't do it right, and we had to stop doing it until we could figure out how to do this. So what we actually ended up doing is working collaboratively with some partners down the road from us, another health system in our area, to do an NIH trial of peer support. And so what we've done is developed a curriculum, a training program for peers, and worked in partnership with the certification process for the state to be able to really come up with a strong process that both supports our patients and the peers themselves to provide care. Right now, we are implementing that specifically for adults leaving our inpatient mental health facilities across our region in 3 of our different inpatient units. We are also about to launch a pediatric version of that peer support program, which is a totally different animal, and that's going to be starting next year as part of a different trial. We expect to have some of these curricula available for people, particularly for the adults, pretty soon in the next year or so after the trial finishes. So I just want to say that, yes, we think this is really important, and we are doing our very best to try and come up with the right process to make it work.
Thank you. Another question is, PSS3 is intended for acute settings only. This seems like a more time effective and safety sensitive screen for collaborative care settings as well.
Yeah, well, I'll be frankly honest. I like the PSS3 a lot. It's a really good tool for our hospitals and EDs. So our inpatient medical hospitals and emergency departments medical, surgical hospitals, and emergency departments are all using this same tool. The good thing about that is there's easy communication within all of our hospitals about what each tool means. There's consistency, so all the docs know what it means for what scores come up and who's supposed to do what. Our primary care is using the PHQ item 9 specifically, and it's just, primary care has got to be the gateway for everyone and every single thing and disease that happens. So we've really tried to work to make things as pragmatic as possible. I am not a fan of having different tools across different settings. So let me be clear about that. But this is what our providers wanted. And so we do now use those two tools to stimulate screening. And quite honestly, we use the PHQ-9 in behavioral health, but actually it's not what precipitates or determines whether people are at risk. We actually do a suicide risk assessment with every single patient who comes in to behavioral health, recognizing in our mind that everyone who has a mental health condition has some elevated risk of suicide. So we're going to do our due diligence and do a full evaluation and assessment with those patients.
All right. Healthcare leaders are burdened with limited resources, COVID disruptions, and many other distractions. Do you recommend a strategy or tactics for getting them on board and for sustaining their engagement?
Well, so we've used a lot of strategies, and I think this is really a really important question: is how do you actually get people to do this? The first thing that I like to do is work with and listen to our providers. They're doing tons of work every day, and so what we like to do is listen to them, and they say, well, I've got all these things going on, and I'm doing all these things. So I'm doing all these things, and this is a lot of work. And so for us, it's, well, how can we replace a lot of bad things with these easier, more pragmatic, good things? How can we take some of the things that are actually a waste of time? Everybody's been asking about suicide risk for years, but they use terrible tools. So how can we take some things out of practice? And what are the opportunities for us to replace bad care with good evidence-based care and make it more structured so that there's actually a process? The other thing is most of our providers have dealt with and worked with how do you respond to somebody saying they have suicide risk in care settings? Well, the problem is we've never had infrastructure to do that. And so what we're doing is providing a solution to them to actually an infrastructure to respond rather than having them be responsible for everything. There's a whole system behind it and a structure rather than an individual person who's a heroic clinician and has to handle each individual situation. We have a structure and work as a system. The other thing I would say is I really piggyback on some of the rules and regulations that have been passed recently. It's like in the hospital, in the ED, they are forced to do this by the Joint Commission. And so we're actually providing a solution to them rather than coming and mandating it ourselves. We're coming in to support and say, hey, let's work together to work through this requirement. The other thing that we do is really piggyback on the competition. There's a lot of systems that are doing these things. And if every big system down the road is doing it and we're not, then we're missing out. So we really like to piggyback on that competition and say, well, so-and-so down the road is doing this, we probably should do it too. That always works with leaders. We've also made the business case using some financial data to show that most of these interventions are lower cost than what we do for most medical conditions, that actually our behavioral health program has actually increased revenue since implementing these programs. And so that we can actually show them how we can pay for the project and the care themselves with what we're doing.
All right, thank you. And are you using computer adaptive testing tools for predicting suicide risk in your system, like the CASI developed by Cheryl King at University of Michigan and pediatric emergency departments?
Yeah, so this is the next generation. And one of the things that we do have a multi-component suicide risk assessment that we do in our behavioral health setting, but I think what we're talking about is more predictive modeling, computerized risk tools that are being developed now over the country. We've actually developed one of these in Mental Health Research Network, and I just want to give kudos to all the people who worked so hard on that, including Greg Simon. We've actually developed a tool specifically that's actually the best performing tool out there right now. And what we're working on doing is implementing that and testing it in some of our systems. So some of the systems in our network have started to test that, but we're working on figuring out a way to get that more broadly implemented. But we haven't done that. We're working on it. So.
All right. And one last question. What advice would you give to health systems struggling to incorporate these metrics into their EHRs?
Well, I would start simple. I mean, start with the three things. One thing I actually have to piggyback on Ed Coffey's, probably his presentation, but one of the things I learned from him is, that I just will take forever with, is he said there's like 1,000 things we ought to do, and 100 things we could do, but really only 3 things we really can do at any one given time. And so what I would do, and that comes from business, the business background, and I give all credit to Ed for teaching me this. But one of the things that I would say is that don't try to do too much. Focus on 3 or 4 key metrics that are most important to you to start. And then once you get a hold on those, then try to broaden that out to a bigger set of metrics that harmonize with the kinds of implementation practices that you're doing. And we've already developed a lot of the specifications for those metrics, so you can feel free and just borrow and steal. All that stuff is freely available. So, I just want to encourage you to use the resources that are available and not to start too big.
All right. Thank you so much. Is there any last minute questions anyone wants to ask? All right, we will wrap up then. Thank you, Dr. Ahmedani, for joining us today. We really appreciate it. In the last session, if you are available to join us with call to action with Jan Ulrich and Dr. Jay Carruthers to end the Aim for Zero Suicide Symposium. Thank you again, Dr. Ahmedani.
Thank you.